Good afternoon, everyone, and thank you for joining today's Aspire to Knock Out Pneumonia Readmissions webinar series, webinar number 2, Align with Related Efforts and Resources and Identify Gaps. We would like these meetings to be very interactive, so we are anticipating that you will be highly engaged in today's session. We encourage you to ask questions and share information throughout the webinar today utilizing the question panel. We will keep all lines muted to cut down on feedback, distractions, and echoing. Before we get started today, I'd like to go over the logistics for today's session. All lines are currently muted and in listen-only mode. During Q&A, we ask that when you ask a question or make a comment, you can raise your hand by clicking on the hand icon on the Grab tab located on the left side of your control panel. Line can then be unmuted. Please announce your name and organization prior to speaking. Please feel free to also ask questions or make comments using the question box located in your control panel throughout the session, and we will address questions as they come in. This session is being recorded and will be made available on the NC Quality Center website and through email notification shortly after the conclusion of this session. Facilitating for you today is Karen Southard, VP of Quality and Clinical Performance Improvement for the NC Healthcare Association, and presenting for you today is Dr. Amy Boutwell, founder of Collaborative Healthcare Strategies. At this time, I'd like to turn the presentation over to Karen.
Okay, well, thank you, everybody. I appreciate you taking your time out for webinar number 2 with Dr. Amy Boutwell. As you know, Dr. Boutwell is well-renowned and versed in care transitions and brings together does not have any exclusive adherence to one particular model, but takes best models and known best practices and provides that insight and education along with utilizing a PACE model where you're looking at your own data and your own processes to determine where you might better serve and improve on your own goals. So we have been having a lot of calls with our members over the course of the last month. And I know folks who have participated in webinar 1 or who have not have been getting the link. And hopefully you've been able to do some of your homework that Dr. Boutwell suggested and prepare for webinar 2. So without further ado, what I want to do is turn this over to Dr. Amy Boutwell.
Great. Thank you so much, Karen, and welcome, everyone. It's great to be here today. So today is part 2 in our webinar series. The purpose of this Knockout Pneumonia Readmissions webinar series is really to support you in moving from transitional care concepts into action. We want to focus on high leverage strategies to reduce readmissions, specifically pneumonia readmissions. And as we go through the series and you get more familiar with the core concepts and the Aspire methodology, will focus more and more on implementation coaching, which is why we want you to work along the process with us so that you can bring your questions, bring your comments in between webinars to the NCHA staff and during the webinars directly to me. Really, the best use of your time on these webinars is to think about your readmission reduction work, your pneumonia patients, and your pneumonia readmissions, and come with questions, challenges, cases, data, ideas for improvement. Invite, especially after today's webinar, your cross-continuum partners as we talk about leveraging warm handoffs, leveraging resources and services that exist beyond the walls of your hospital, and again, engage with your team here, because we are here to help you make progress, not just teach you how to reduce readmissions, but help you actually make progress on reducing those readmissions. Every day you have pneumonia patients that are being discharged, and those are the patients that we need to be worried about right now, today, coming out of this webinar. So for those of you who are new, just a reminder, we're using the Aspire guide. I wrote the guide, and it came out of 5 years of field work, including great field work that happened in your neighboring state of South Carolina. The Aspire guide, I hope that you have, those of you who were with us last month have heard of it now, but it's now becoming the predominant guide that has been spread through excuse readmission reduction collaboratives across the country through the Agency for Healthcare Research and Quality, the CMS Partnership for Patients, major national quality improvement collaboratives, as well as the NCHA, and there you are on the screen. So it's great to have North Carolina join the group that's working with these methods. The ASPIRE framework, just as a brief reminder, is an acronym to remind us of really the two-part strategy that helps get results: design and deliver. And if our aim is to reduce pneumonia readmissions, which you see on the left-hand side of this driver diagram, we want to make sure that we balance our efforts in a data-informed, whole-person design of your readmission reduction work, as well as then moving into implementing a data-informed whole person set of strategies in order to reduce your readmissions. And as I have had the good fortune of studying several hundred hospitals across the United States, I've noticed that one of the key differentiating factors in getting success is when readmission reduction teams move straight to a solution. We have a readmission problem, we're going to start to make post-discharge calls. We have a readmission problem, we're going to start to make appointments. And we move straight to solutions and action steps, which, as you can see, would only be one element here on this ASPIRE set of secondary drivers. So ask yourself today, we are still in the design bucket. Ask yourself today, do we really understand our pneumonia readmissions? Do we understand the data? Do we know what our current state is? Do we understand root causes of readmissions? And today we're moving into S, which is, do we understand what's going on within our hospital that could be leveraged or mobilized or repurposed to help our pneumonia patients not need to come back to the hospital so soon? And not only what's going on within our own organization, but what's going on across the continuum, because most of the services and supports, quite honestly, that your pneumonia patients need are those that are going to be found in the post-acute and community-based settings. So this is where we are today, and as you can see, our curriculum is to basically walk through the entire ASPIRE guide by the end of the summer, and then by September, we'll have you get ready for our in-person learning session in October, and coming out of the in-person learning session, we will then harvest from you what you've done, what you've accomplished. And so I'll remind you that as we go through the curriculum here for the series of webinars, what we're really doing is we're asking you to do work all along these months, not wait and learn, but learn and act as we go through all of these webinars, because we want you to really have stories of success by the time we get to the end of the year, which is not very far in the future, as all of you who are experts in readmission reduction work will know already. So the objective for this session is to know what transitional care practices, processes, tools, services already exist within your hospital, to know what transitional care services and supports are in place in the post-acute and ambulatory care settings, those clinical settings, and something that you may not have on your radar screen quite enough yet is know what services and supports are available in the community, including behavioral health, social services, supportive services, logistical services, things that go well beyond the clinical domain, but are nonetheless essential to help stabilize our patients so that they don't come back to the hospital if at all possible. So before we get into that topic, I want to connect the dots between last month's topic and today's topic, because they are directly and integrally related. So I'd like you to reflect on what we covered last month and your past month of work, and some of the recommended steps that I encouraged you to take. So question number one, and for those of you who are on the WebEx, you can chat this in, and I'll see it, especially if you chat into organizers or panelists. So question is, what did you learn in the past month about your pneumonia readmission patterns? We gave you a lot of great data, a lot of North Carolina specific data. It was an incredible wealth of pneumonia readmission analysis that we covered in March. So what did you take away from that? And as I wait for you to chat in, I hope some of you will, questions for your consideration. And I want you to engage right now and ask yourself, do you know the answers to these questions? Because if you don't, you may not yet be ready to move into action. So number one is, what is your hospital's pneumonia readmission rate? Do you know what it is? Do you know how to get it? Do you have it on a monthly basis? In addition to your hospital's pneumonia readmission rate, how many pneumonia discharges do you have per day? This would be in the adults. We're talking about adults here. So how many pneumonia discharges do you have leaving your building on a day-to-day basis? It's really important to quantify the target population, because that will paint a picture as to whether or not you can serve and enhance the transition of care for all of your pneumonia discharges, or if you're going to need, a multifaceted and segmented strategy because you can't keep up with the volume. Most community hospitals, and definitely our smaller community hospitals, can enhance the transition for all pneumonia discharges per day. That sounds scary, but when you quantify it on a day-to-day basis, it's actually not that bad. It might be 1 or 2 or 3 or 6. But even then, that is not unreasonable to focus on 100% enhanced transitional care. Number 3, when you know how many discharges, pneumonia discharges there are per day, then you want to now know, and where are they going? Because if they're going home without any services, or if they're going home with home health care services, or if they're going to a skilled nursing facility, your handoff, transitional care, and follow-up strategies are different for all 3 of those populations. So quick example, if you're a hospital with 3 pneumonia discharges on average per day, one's going home with home health care, and one's going to SNF, well then you have right then and there, you have a multifaceted portfolio of strategies where you can do a warm handoff to the receiving nurses and clinicians in home health and to SNF, and you can do a warm handoff to the care manager or the PCP in the primary care practice. You can deploy some enhanced services to the person who's going home or with home care, but you don't have to have the same strategy for all 3 pneumonia patients that are leaving the house today if they're all going into different levels of care. So that's part of the reason why I encourage you not just to follow a pneumonia readmission rate globally, but break it down into bullet point 2, bullet point 3. Quantify how many discharges in your target pop, and then where are they going, because your strategy and your operations can be very different based on discharge dispo. And then importantly, as we pointed out last time, what is the readmission rate among your patients discharged to skilled nursing facility? We found last time, and this is consistent with national data, this is nothing different about North Carolina, but patients who are being discharged to post-acute care have much higher rates of readmission. But if you ask providers, if you ask us doctors and nurses and case managers on the floor, we think that discharging a patient into post-acute care is a safe and sound discharge plan that will minimize their likelihood of being readmitted. Well, it's just not what the data shows. And so what we need to do is we need to say, ding, 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 if they're being discharged, if my pneumonia patient is being discharged to skilled nursing or to home with home health care, I now need to do 3 more things in collaboration with my colleagues in post-acute care in order to minimize the risk of readmission. I now know this person is at higher risk, not lower risk of readmission, because they're going into post-acute care. And we covered that in the data, and that's part of the linkage between last webinar's content and today's content, which is what's going on in the skilled nursing facility that you may or may not be aware of? Do they have on-staff PAs or SNFists? Do they have telemedicine? Do they have interact response protocols with their nurses and their medical directors? What's going on in the facility? Because now we need to be more worried, not less worried, about our shared pneumonia patients. And then finally, another little bit of insight that I took from last month's data were those early bounce backs. What is going on with those early readmissions, the patients who are coming back within 7 days of discharge? They probably have a unique set of root causes that are important and potentially actionable and different from overall patients that get readmitted. So I want you to really engage with this and push yourself and ask your teams and whoever you're watching this webinar with, or bring this back to your readmission team. We are committed in the Knockout Pneumonia campaign to reducing pneumonia readmissions. Do we know the answer to these key bullets? And if we don't, then please make sure you take a deep dive and get the answers so that you can move forward in a data-informed way. The other content we covered last time was, do you really understand the root causes of readmissions? Why do your patients, why do your humans with families and challenges and competing priorities, why do your patients return to the hospital within 30 days of a pneumonia discharge? And we clinicians, we get really excited about clinical risk scores and clinical parameters. And one thing that's really powerful, if there's nothing else you get from me in this entire webinar series, it's that the most powerful insight into what we can do to reduce readmissions comes from asking patients what their experience was when they left the hospital. So I'm going to play a video clip for you that you can see me teeing up here. This is from a readmission program that I helped support out in Arizona, a million miles away. One thing you're going to notice is that on the webinar platform, we figured out, that the video or the audio was not playing through the webinar platform. So I'm going to play the audio through my phone, which you should be able to hear okay. And this video is just 1 minute, 54 seconds long. So hang in there and watch the story of Mrs. McDonald, who was discharged after a pneumonia admission.
I was hospitalized for pneumonia. I was in the hospital for 6 days. I was given all kinds of treatments, nose sprays, breathing treatments, things that I really didn't understand, but a nurse was always there to help me with it. However, once I got home, I sort of panicked because I didn't remember how to use all the equipment. I originally heard about care transition programs through their publicity in the newspaper when they first started out, and I thought, I don't need that. I have been in the hospital so many times that I know everything there is to know. But then I realized I really did need their help. Linda is a care transition nurse who first called me on the phone and then arranged to come to my home. She came twice, and she was wonderful, very caring, made me feel very confident. She was very understanding. I never felt rushed. She explained all the things that I needed to know, and also symptoms that I should watch out for. Sun Healthcare Transition Program is a wonderful program. It really helps you transition from the hospital to your home. And I advise anyone who's been in the hospital to take advantage of this very wonderful program. And best of all, there's no cost involved to you.
Okay, so I hope you could hear that all right. Let me get back onto the webinar. There we go. So think about Mrs. McDonald and think about, what did Mrs. McDonald need? So when I look at Mrs. McDonald's video, I see a woman who is very put together. She is self-assured. She's clearly independent. She's clearly cognitively very sharp. And I think that if I were her doctor, I would have thought she doesn't need anything. And what I love about Mrs. McDonald's story and her video is that she didn't think she needed anything either. But when that transitional care nurse got there, you know, and started to help, it's a very human experience. Mrs. McDonald realized, oh, I did have questions. I wasn't clear about this or that. I am a little fuzzy in my memory about what I was told before I left the hospital. I did need her to go over my medications and clarify and repeat a few things. And these, to me, these are robust and truthful and effective strategies to reduce the chance of a readmission, especially for what I'll call our moderate risk patients like Mrs. McDonald. She had pneumonia, which makes her high risk in our target population. And what she needed were these things that you see on the screen. She needed a reminder, opportunity for clarification, repetition, support. She needed to feel just a little bit more confident that she had her instructions straight and that she understood what to do. She had Linda as the point of contact, and whenever you can possibly do so, include the home visit. Linda came to the home, and that's where Mrs. McDonald realized and was willing to realize that she actually valued and benefited from Linda's help and support. So, question for you is, as we think about pneumonia readmissions and pneumonia patients and what you're putting in place in order to reduce the rate of pneumonia readmissions, are these the services that you're putting in place? Are you meeting the actual needs of your patients, like Mrs. McDonald? Now, Mrs. McDonald is not the only type of pneumonia patient that we have, of course. And so you'll remember that I encouraged you to please, please, please interview 10 of your pneumonia patients who are readmitted. You go find them in the hospital. They're upstairs right now. And you can get this job done within a week. But what I encourage you to do is meet 10, because once you meet 10, you're probably going to meet the people that I've met over the many years of doing this work who had pneumonia, who were discharged, and who were readmitted. And here are some of the root causes of pneumonia readmissions that I see in my patients and in my work nationally. So there are a group of pneumonia patients who are truly on the end-of-life trajectory. They are our frail elders, and we are treating an acute illness when really there is a bigger picture and a larger conversation to be had. But we focus on the rescue treatment of the acute issue, and we discharge people on antibiotics, and we tell them to follow up with their PCP, and we don't address the goals of care. We don't have the family meeting. We don't refer to hospice in a timely way, which is why we all know that hospice is underutilized. And so ask yourself, do I have some of those pneumonia patients who really actually needed the things you see on the right-hand side of the screen in order to safely and effectively reduce the chances of readmission? There's also a small segment of patients, and again, it depends on exactly the type of hospital you have. But at many of our teaching hospitals or our hospitals who have a lot of SNF patients, we have some recurrent aspirators, and they're coming in and they can be very frequently admitted. But we know that they have swallowing issues. We know that they aspirate, choke, get a little hypoxic, but then they recover and they don't actually have pneumonia, but they're coming back because of the aspiration. And so again, ask yourself, what do we do with that small segment of patients who are aspiration pneumonia? Because I think that is a distinct subgroup. Number 3 is that I know that really one of the more common stories that I hear when I readmit patients with pneumonia is I was taking my, I was taking my IV antibiotics in the hospital. They switched me to PO. I was home for 2 days, and now I'm back with voluminous diarrhea. Whether it's antibiotic associated or C. diff, they're back because they cannot self-manage the new diarrhea. And honestly, what we might be able to do is we might be able to, first of all, anticipate and create response strategies for the fact that a high percentage of our patients who leave the hospital for treatment of pneumonia on oral antibiotics, they will develop diarrhea. So let's not be surprised by that. Let's have a plan. Let's anticipate that for our patients. Let's tell them who to call and what to do. And please, let's have it not be call 911. You know, let's try to develop alternative pathways for them to be seen and managed and supported in the outpatient, ambulatory, or even skilled nursing setting, instead of coming back for a readmission, which is really for nursing support. A cousin to that, again, I've seen these patients with my own eyes. I went out, somebody, you know, lowered my Coumadin dose, because they knew I was leaving on 14 days or 10 days of antibiotics, and but I didn't have my INR checked until 7 days later, which sounds good to us, but they're on a new antibiotic regimen, their diet has changed, and boom, they're coming back to the ED with high INR, and we're readmitting them for observation for high INR. That's a story you're going to hear. There's people like Mrs. McDonald who come back because they forgot instructions, they were a little bit confused, they were a little bit worried. I think I shared with you in March the story of the HIV patient who had pneumonia, so she was discharged with pneumonia. She came back 8 days later because she was still coughing. No fever, no chills, no sputum production, she was just coughing, and she had a very legitimate, simple question, which is, should I still be coughing? But instead of focusing on the straightforward question, she was readmitted, even though that wasn't necessary. And then, of course, we have what many of us in the field would consider difficult or challenging or not fully engaged patients. I like to generally categorize this as they lack some self-efficacy. And the solution for any person, whether it's heart failure, COPD, or pneumonia, or anybody who has low self-efficacy in self-care and navigating the delivery system, is in-person navigation and in-home follow-up. So I'm kind of hitting you with a bunch of examples of root causes and potential responses to your different pneumonia patients, because they are heterogeneous, but there are going to only be 5 to 8 major categories of root causes of pneumonia readmissions. You might like and work with some of these categories, and you might decide you have your own categories. That's totally fine. But the reason why I'm emphasizing and going over the importance of understanding root causes of readmissions is because what you can see in the response column here is a whole bunch of partnerships and supports and alternatives to readmission, and that's where we need to know who can we partner with, who can we develop shared protocols and processes with, who can be that supportive follow-up and navigation service, etc. And so that's exactly the question at hand for today, is that now that you know, hopefully, your patterns and root causes of pneumonia readmissions, what are we going to do about it? Especially if we can't wave a magic wand. So this gets us into inventory and know what is available and ask ourselves, are we optimizing the resources that do already exist in our hospital and in the community? So this is a quote from my field work. One champion of the readmission effort said, "We run the care coordinator pilot. I think nursing is working with IT on getting a high-risk flag in the record. I'm not sure how that's coming." You know, and it's kind of like what really emblematic probably of your readmission work. You've all been mobilized and deputized for in some way through the roles that you play Maybe it's quality. Maybe it's that you're a critical care pulmonary doc or nurse from pulmonary clinic. Maybe you're on the readmission team already, but you wear different hats and you come from different departments. And so one thing that's really important to think about really quickly, it doesn't need to take long, but it's worth 1 or 2 meetings about, is to recognize that whether you work in a small hospital or in a large system, readmission reduction activities have proliferated over these past several years. And some of the efforts have developed in isolation from one another. There's, risk scores in the EMR, there's flags, there's nursing initiatives with Teachback and bedside risk assessment, there's care management with handoffs and appointment making and discharge phone calls. There are clinical initiatives around sepsis and early appropriate treatment and antibiotic stewardship. There's so many efforts that have proliferated. It's a great opportunity because you have a specific mission, which is to reduce pneumonia readmissions, your organization and ask yourself, what resources, processes, protocols, and services exist, even if they're not all right now helping my pneumonia patients? What out there has been stood up that we might be either able to model or replicate or collaborate with or align with or even deploy for the benefit of our pneumonia patients? So here are a couple examples of resources or assets to get specific. Readmission flags. A lot of EMRs these days have an indicator this patient is returning within 30 days. That should be disease nonspecific. That should be for anybody who is literally returning to the hospital within 30 days. But then ask yourself, what about the high risk flags and all these risk scores that are baked into your EMR? Do they include pneumonia? You want to know, is the person in bed 327A, do they or do they not have pneumonia? Are they thus one of our high risk concerns? Similarly, post-discharge follow-up phone calls. Hospitals have a huge variety of role types and departments that are doing these post-discharge follow-up phone calls. A question to ask is, who's doing phone calls, and are you calling the pneumonia patients? Probably not. Maybe yes, maybe no. They're for sure calling the heart failure patients. I'll tell you that much. But it's a good question to ask. Who's doing them, and are we calling the pneumonia patients? Are we calling all of our pneumonia patients? If yes, great, and put that person on your committee. If no, ask why not, and could we include pneumonia? So too with other common initiatives like scheduling appointments, either through unit secretaries or through a standard work of case managers at the point of discharge, or through centralized appointment scheduling. Ask ourselves, are we doing that service for the pneumonia patient? If you have pharmacists or pharm techs doing med rec or optimization or teaching or med to bed delivery, any of those things, are we doing it for the pneumonia patients? And if you have an ACO or a bundled payment team, they usually have care navigators and other types of supports. Are they targeting the pneumonia patients? All of these teams have their own rubric, their own history for who they started with. And now that you're championing the pneumonia readmission initiative at your hospital, you should at least have have the awareness of what's going on in any or all of these various domains. And then B is pursue the legitimate question, hey, can we add pneumonia to this list? What would it take? How would we do it? So here's a hospital inventory tool that you can, go through. You can circulate it among your readmission committee or among your colleagues in different departments to identify some key readmission reduction efforts that you may not directly be a part of or aware of, but you want to try to take this opportunity to harvest on one page, if you will. You can then, when you have yourself, your committee, you want to reach out to make sure you're covering some other key departments that are enumerated here. You want to then ask, as a group, ask yourselves the honest question, are we coordinated? Is there any duplication that we are discovering? And then by filling out a tool like this, you can use this tool. It's downloadable on the Aspire website, and we made it as a Word doc so that you can edit it. If you don't like one of these lines, if it doesn't relate to your organization, then just delete it and put something else in that makes sense for you. But what you do is you fill it out, and then it's a two-part tool, right? Then you know what does exist, and you also very clearly see how many boxes are unchecked. That is food for thought. That is your gap analysis. Then you say, well, if Amy Boutwell and the Aspire research team felt like it was important enough to put this on the list, and we don't have that, that's a delta. That's a potential delta, a potential gap for your consideration. So you ask, do we have the administrative and the clinical support that we need? And then you get specific. You say, okay, so we have, for example, as I said before, we have a flag. Does the flag include our pneumonia patients? We have phone calls. Do the phone calls include pneumonia patients? And you want to ask not just sometimes, but which pneumonia patients? Is it just Medicare discharged to home? Or is it all Medicare patients regardless of discharge disposition? Or is it all pneumonia patients regardless of payer? So you really want to know, of all the people with pneumonia leaving our building, exactly whom among them does any one of those services, supports, or processes apply to? It's a very powerful tool if you engage in detail with it. So then the next step is to look beyond your walls and to ask the same set of questions of the post-acute and community-based environment. And the most common thing I hear from literally hundreds of hospitals from coast to coast and everywhere in between, north and south, rural and urban, literally every hospital in America says this to me when I start this topic with them. Yes, you just don't understand. There are no resources in our community. Our community is different. Our community has had struggles. Our community has had cutbacks. I'm not being flip when I say I have literally heard every community tell me that. The question is not whether do we have enough resources, because I am with you. You probably don't have enough resources. The opportunity I'm inviting you to engage with is what does exist. And just as your work in the hospital has evolved quickly over time, and there are numerous moving parts, and it's hard for you to even keep track of it all, and you need to do your own internal survey and inventory, so too is it worthwhile to do an inventory of the community and start with the question, what does exist? What has changed out there? What do we not know about? Instead of starting with the question, our community is poor, rural, urban, underserved, lacks this, lacks that, underfunded, etc. Start with saying, we're going to go find what does exist. And whenever you do that, sure enough, you do find plenty of things that do exist. And that really is my experience in every community, including some of the most desperately under-resourced communities. So where do we go to look? Well, post-acute and community providers might offer services and supports in the post-hospital period that you are unaware of, again, because their world's changing quickly, your world's changing quickly, and you just haven't kept up with each other. A great example that I'm sure is flourishing in North Carolina, so you have stood up a bunch of patient-centered medical homes over the past several years. Wherever you find a patient-centered medical home, you know there's a care manager. You know that part of their process of care is to know when their patients are in the ED or discharged and to make post-discharge phone calls to get them back into the clinic to review their meds and to get them a doctor's appointment. And so that is a very robust service that you can know is happening. Now, just because they're a PCMH and they have that process doesn't mean that everybody is aligned in considering the pneumonia patient high risk of readmission. So you have some work to do to connect the dots, but we'll talk about that another time. As long as you know which of our patients are being discharged back into the care of a patient-centered medical home, and you know what those patient-centered medical homes are wired up to do, then we can work on collaboration and optimization in the future. Another great example are home health agencies. And every home health agency that has a measurable, objective story of success in reducing readmissions for their home care patients, 100% practice is front-loading home visits. And if you don't know what I mean, we can answer that question offline. But basically, in a home care episode, there are usually the encounters are staggered rather evenly over time. And of course, for our patients who are leaving the hospital who are at high risk of readmission, what we want to do is we want to balance and weight or front load preponderance of those visits early post-discharge and then space out the follow-up accordingly over time. That is a key question to ask your home health agencies. And then another place to look are your skilled nursing facilities. You all know, and I hope you do know, that your skilled nursing facilities are also exposed to readmission penalties. They are exposed, in fact, to a much higher standard than we are in the hospital. They are accountable for all cause readmissions. CMS took them straight to the varsity level when it came to readmission reduction work. And so we have a shared and highly aligned interest in making sure that we collaborate hospital to SNF, SNF to home, and to manage care across the continuum so that that pneumonia patient who's going from us to the SNF, from the SNF to home, does not end up back in our emergency room within 30 days. And so increasingly, you're going to find that your SNFs are either interested in doing or have started to do some version of transitional care themselves, which of course would look like the type of hospital to home work we do with arranging visits, home services, follow-up appointments at the point of discharge from SNF to home. So I advise you to go inventory who's doing that or who's thinking about doing that in your SNF provider community. So that's in the clinical services area. Another robust area, and again, I'm not from North Carolina, so I'm going to look to you to look into this yourself, but increasingly health plans are engaged in some type of transitional care, high-risk care management, mobilizing kind of non-traditional services and supports. And believe me, I know that we don't classically consider health plans are allies in the hospital setting. We have our own battles, but utilization review and payment battles in this space are different from finding the care management and cost avoidance side of the health plan. They are, in fact, two different sides. And one thing that I've really learned in my Medicaid readmission work is that if you have a high-risk patient who is one of their members, they do actually want to know about it. They very well may already have assigned a care manager, and more often than not these days, even including just yesterday when I was in New Jersey, these teams these health plans are deploying local teams to do the in-person transitional care that you might wish you could do if you only had the resources. So yesterday I was in New Jersey, and a health plan, Medicare and Medicaid health plan in New Jersey, raised their hand during our collaborative meeting and said, I want everybody to know that we have social workers, we have complex care managers, and we have now started what's called an advocacy team to help people with the legal aid, the housing issues, the landlord issues, the electricity issues, and paying the bills, and all that kind of, all the social needs that confound recovery. And so, so look for that. The world is changing. And another quick example, I'm sorry I don't have a North Carolina example for you, but in South Carolina, when we did our Medicaid readmission collaborative, we had the medical directors from all, I want to say it was all 5 Medicaid managed care organizations at the time in all of South Carolina come to our collaborative, and they said, we desperately want to know if one of our high-risk patients, if you identify a patient as high risk of readmission and they're in the hospital, we will be happy to send a nurse transitional care manager to meet with the patient, meet with the family, execute that transitional care. Please let us in. Their biggest problem was they didn't know that the patient was there. They didn't know the patient had been flagged as high risk, and they are not let in the building, if you will. So lots of food for thought. The world is changing, and if you're thinking, gosh, we don't have any resources, then what I'm hearing out there is that there very well may be some resources that are mobilized through the health plan. Okay, and then finally, there's a wealth of other resources or assets that could be leveraged. Of course, I'm well aware in North Carolina about CCNC and the successes that they've had through community-based care management. And then moving beyond that particular patient population, behavioral health clinics, it's not just about behavioral health prescribers or counselors, it's about peers and advocates and groups. And many of these clinics also have transportation resources, or even linkage to employment or other positive structures in somebody's life. And so reaching out, I challenge you to reach out to one behavioral health clinic, the largest clinic in your county, for example, and just get to know, what do they offer? And beyond prescribing therapeutic medication, if you will. What's the milieu, as they call it, of services and supports and therapeutic interventions that go beyond medications? And then finally, volunteer, faith-based, elder services, social service agencies. This is where you're going to think, oh, we don't have anything in the county, but it's not just public resources. It's the entire nonprofit, community-based, faith-based, and volunteer spectrum that you want to make sure you're looking into. Because why? Well, a lot of your older adults that are discharged with pneumonia, they are lonely. Their kids live somewhere else far away. What they really need is somebody to check in on them and express, some concern. Hey, Mrs. McDonald, why didn't you? I thought you were supposed to go to the doctor today. Why didn't you go? Don't you think you should call? Maybe I could call for you. And that's not a clinical intervention. That's a concerned neighbor, a concerned volunteer, or member of a congregation or faith-based community. So with that, this is tool number 5 in the Aspire guide. Again, downloadable and editable for your preferences. I encourage you to work with this tool and ask yourself, where can we find that kind of support, the human support, check-in, peers, navigators, medical legal advocates, senior service agencies, faith-based or community volunteers. And once you work through an inventory like this, you then look at it and ask yourself, are these strong partnerships? Do we have any sort of formal partnership with any of these? Do we have an informal arrangement with any of these, or are we just kind of merely aware of their existence? Are we optimizing the resource that they offer? Is linking our patients at the point of discharge as easy as it needs to be? And I always like to ask ourselves the question, I hit the easy button in the hospital and a patient gets screened for and placed in a SNF or home care agency. And, it is a very well-oiled process, right? You get screened, you either qualify or you don't qualify, you get offered, you accept, you don't accept, and then you get referred and linked. That is exactly as easy as it needs to be to get somebody connected to any one of these other supports in the community. Now, you don't need to boil the ocean. I don't want you to. But from this exercise, you can ask, gosh, and you will be able to see, gosh, okay, we were really excited and proud of ourselves that we had, quarterly meetings with 3 SNFs, and that is a great thing to do. But then you will see, but we really haven't extended that to the 10 PCMHs in the area, or to the 3 home health agencies that we mostly send our patients to, or the county elder service support, social service agency that we've never really met with, actually, if I think about it. So that's what I just want you to break it down and say, I'm sure you're doing something good with connecting some patients to some services. Use this opportunity to inventory what exists, and then are there gaps that you want to prioritize and work on through this Knockout Pneumonia campaign. I've already kind of covered this. One thing that's just amazing, every time we get together in a statewide multi-agency collaborative, somebody in the back of the room in the last 5 minutes of the day raises their hand and says, I don't know why nobody's talked about adult day health all day long. I'm telling you, this has happened to me about 7 times. So I don't want it to happen in North Carolina as well. And one thing that we often don't think about enough is, what does adult day health offer? We think about our known partners, SNF, PCP, specialty, home health agencies. But why adult day health is not on our short list is not entirely clear to me, especially, and some people will say, well, it's because it's not, the requirements, eligibility, it's not covered, et cetera. One thing I'm learning and seeing in the field, and in fact, I just saw this yesterday in New Jersey, is that some readmission reduction teams are saying, we're going to try, this isn't for all pneumonia patients, but for those patients who really do need and would benefit from structure in their day, socialization, nursing oversight, help with meals and medications, and a place to be maybe when their family members are off at work, right? There are so many benefits of this type of a structure that just yesterday, one of the hospitals in New Jersey said they are working on negotiating a day rate with a local adult day health organization, so that they would rather pay for, if you will, X number of adult day health days than hire another, 2 or 3 transitional care nurses. It's an interesting thought. It's a very interesting thought. So let's not let the financing necessarily cut us off from really taking another look at what services are provided and what are the benefits of these services for some of our pneumonia patients, and how many of our pneumonia patients might just benefit from getting connected to this type of a service. And again, this is just illustrative of any of a number of services that we're currently not optimally utilizing in the community. It happens to be, I took the screen from this information from a Google search of adult day health care in North Carolina. And this is the website, in case you don't know what I'm talking about. I know all of you social workers do, but in case you don't know what I'm talking about, this is your North Carolina link at the bottom of the screen, and these are the actual live links from the website on the Department of Social Services and the Area Agency on Aging. This would be a great screen to even just say, okay, coming out of this webinar, we're going to just go ahead and look into our local Department of Social Services. What do they do again? The Area Agency on Aging, what do they do again? And adult day health care, what do they do again? And if you just started with those 3 things, I would be most grateful. So here's an example, an example from the field of a hospital in Maryland, Bon Secours Baltimore Health System, so Baltimore. Obviously, they're going to say to me, you don't understand, we don't have any resources in the community, which is what they did say. But we went through the exercise. We did the internal inventory, we did the community-based inventory. And I won't read you, of course, all the bullets. Really, this slide is meant to be illustrative. It almost doesn't matter what they found. The point is, they found 7 or 8 things that were relevant, that were going on in the hospital, that were not all aligned by any means. They found 7 or 8 things in the community that seemed relevant to their population of high risk, high utilizers. And based on looking at what are we doing, what's available in the community, they came up with exactly the right next step, which is to say, so what should we do with this information? And this is their conclusion. They said, you know, because of this information that we see, we need to do these 4 things. And they were all 4 action steps that were feasible, reasonable, and they actually did it moving forward as a result of going through this exercise. So, as we kind of wrap up this topic here, I'd like you to think to yourself, which internal, or once you do this inventory, you're going to want to think to yourself, which internal hospital-based processes or resources could be mobilized to better serve our pneumonia patients. Maybe that's palliative care consults. Maybe that's pharmacist med optimization or med-to-bed delivery. Maybe that's more consistent social work consults or transitional care linkage. Ask yourself the question, what processes or services exist with post-acute partners? And are those processes being applied consistently to our pneumonia patients? Maybe that's warm handoffs or circle back, my favorite quality improvement initiative from Carolina's healthcare system. Virtual co-management, SNF, SNF providers that can see patients repeatedly in a timely way to support them post-discharge without a readmission. ED treat and return pathways. We'll talk about all this stuff in future webinars. Third is what services exist in the ambulatory care setting, and are they being delivered to our pneumonia patients? Many times, you're going to find different organizations' risk stratification or risk identification might not include your patient population of interest. But a conversation and the data that we mobilized last time would probably be enough to convince them to add your high-risk patients to their high-risk categories. And then finally, what services exist in the community that can better address our pneumonia patients' need for supportive service, check-in, social contact, and reassurance in the days following discharge. So in conclusion, I submit to you the following 5 recommendations. Number 1 is I really recommend that we move from analysis into action, and let's just start to develop a running list of the root causes of pneumonia readmissions as you encounter them. Just start a table, and every week or hopefully you're meeting more often than every month, but every week or every other week as you meet as a knockout pneumonia action team, review your pneumonia patients who have been readmitted and compile a running list over time of the root causes that you are finding out there in your patients. Number 2 is use that list, as I showed you on the table, is to match root causes with what do we do about it. And that will bring you focus and relevance to your readmission reduction interventions. Number 3 is know whether or not you have hospital-based services that can address some of those root causes. Ask your SNFs, home health, and PCP and other clinical providers if they have any supports and services that would be relevant to the post-hospital care of your pneumonia patients. And 5, learn about the community services and supports that exist that could be mobilized to better serve your pneumonia patients. And be willing to know that you might not know even who to ask or how to get started, and that asking probably social work, your social work department, and then what I've learned is an important tip is convene a small focus group of 2, 3, 4, 5 social service agencies in your community, and they will tell you what you need to know. They will save you hours of ineffective research if you just bring together a small working group. So with that, I thank you so much for joining webinar number 2. Thanks for your commitment to reducing readmissions. Please send us your questions. Please share your progress. As we move forward, we're going to want to hear more about what you're getting out of this, what you're doing, and how you're working along with us. And with that, I will turn it back over to Karen and Trish to close us out. Thanks.
Okay. Thank you so much, Dr. Boutwell. And while we're queuing up, if anybody has a question, they can signal either raising their hand or they can chat it in at this time. So one of the things, we have a few, just to briefly, One of the things we have found in making our calls throughout our hospitals is that everybody is very focused, and like you said, they have transition work going on. So I think your tool, your assessment tool, is a great way to take a pause and do an inventory and reflect on their data. Just go back and drill down their data. Would you say that's a really good place to start?
Yes, I mean, our readmission, we have to reduce all sorts of readmissions. And so the entire methodology of the Aspire guide is payer and diagnosis non-specific. And so you know, if your hospital has a strategy that says we're reducing all cause readmissions, we're reducing pneumonia readmissions, we're reducing XYZ readmissions, you can use all of these methods and apply it with your target population in mind. So hopefully you find relevance. We're all gathered here today because of pneumonia and the imperative of pneumonia that we see in the data, but you can use these methods to achieve your readmission reduction goals, hopefully with pneumonia patients in mind.
Yeah, that's great. That's really good. I think these tools are really spot on and easy to use.
Great. Thanks, Karen.
All right. Anybody have any last questions or anything? Okay. Well, this will conclude our webinar today, and we want to again thank Dr. Boutwell for taking the time out to present that. And over the next month, we'll be working on making sure that folks have access to the tools and be encouraging and coaching them to direct to use those tools within their team. Is there a question?
Yes, a question has come in.
Yes.
It says, if a patient has readmissions after going home with pneumonia but comes back as having a UTI, is that a readmit?
Yes, ma'am. Yep.
Yeah.
So the simple definition to keep in your mind is, did they leave the hospital and did they come back? That's the definition of a readmission. And in our case, it's, did they leave the hospital with pneumonia? Did they come back for any reason? And PS CMS says, did they go back to any hospital? Okay, so yes, if they came back with a UTI, that's exactly, just think about Mrs. McDonald. And I've just seen the notes here. I hope you could see the video, and if you couldn't, please go and watch Mrs. McDonald, because you'll always remember her as soon as you watch the video. That's exactly the kind of lady who would be discharged with pneumonia and come back with a UTI. That's what transitional care is all about.
Yeah.
So thank you. Great question.
Yeah. Another question. All right. No other questions. So thank you all very much.
Okay. Have a good day.
Have a good day.
All right. That concludes the webinar for today. You may all now disconnect. Thank you.